Okay.
Chalo. Shreya, can we have the slides now? Introduction slides. So, a very warm welcome. Good evening to 168th edition of this Thursday Musings. A very important topic. People talk about the side effect of medications, problems in pregnancy. Now, what Dr. Vasan is trying to do is trying to tell us what is the thing if we do not treat the illnesses. What is the toxic effect of illnesses on the pregnancy? So everyone is in the mute mode. The panelists can unmute themselves. The questions will be invited in the chat box. The session will be recorded and posted on our YouTube channel. Next slide, please. Handing over the session to Professor Dr. Tufan Pati sir, who despite being in travel is with us. Sir, thank you so much. Over to you.
Thank you, Dr. Alim. Thank you and very good evening to all of you, all the participants in this meeting. And over to the next slide. We have, as usual, always two vibrant, energetic, dynamic moderators, Dr. Amrit Patadosi, Professor of Psychiatry from Bhubaneswar, who is also the President of IPS Odisha State Branch and the Secretary of IPS Eastern Zonal Branch, is here with us, though in Sajib, and Dr. Alim Siddiqui, Professor of Psychiatry from Lucknow, who is the Treasurer of Indian Psychiatric Society. He is with us, both are from the very beginning, quite vibrant. Next slide, please. I have the pleasure to introduce Dr. Indumati from Coimbatore. She is a consultant psychiatrist at Bhajikati Mental Health Center. She is there from 2009 till 2020. Founder and consultant psychiatrist of Mathis Mind Care Clinic since 2020. Recipient of IPS Women Resident Award 2021. Co-author of CPG of IPS and Management of Psychiatric Disorders during the perinatal period. Currently advisor for Samanvi Women Empowerment Committee of IPS South Zone. Played various roles as member, co-chair, and chair over the last 3 years. Areas of interest: women's mental health, perinatal psychiatry, community psychoeducation, mental illness, and life skills. Welcome, Dr. Indumati. Next slide, please. Dr. Sillakmi Pingnelli from Telangana. She did MD from Lady Handel Medical College, Delhi. Is professor, Government Medical College, Sangareddy, Telangana. Senior psychiatrist, Rosni Counseling Center and Rosni Child Guidance Clinic. President, Hyderabad Psychiatric Society, 2020 to 21. Editor, Telangana Journal of Psychiatry, 2017-19. Convener, Boundary Guidelines Task Force, IPS. Editorial board member, Archives of Mental Health. Areas of interest, child psychiatry, liaison and psychiatry, public health awareness activity. Welcome, Dr. Silakni. Now, the meeting belongs to the chairpersons, Dr. Indumati and Dr. Fingerly. Please take over. Someone will introduce our esteemed speaker, Dr. Vasan. The other introduce the topic. Over to the chairpersons, please.
Thank you, sir. And thank you, Thursday Musings, for giving us an opportunity to chair such an important session. So to start by introducing the speaker, Dr. Challa S.V. Krishnavasan, who's from Andhra Pradesh, who's currently working as a child and adolescent psychiatrist in Anurag Special Care Unit, Anurag Hospital, Kakinada. He is MBBS from Guntur Medical College, he's MD from Visakhapatnam. And in addition to his MD degree, he's done numerous other qualifications as well. For example, a certificate course in Essentials of Palliative Care in Visakhapatnam. He's also done a PDCC Child and Adolescent Psychiatry from JIPMER. He's a postgraduate in Diploma in Medical Law and Ethics from NLS Bangalore. And he's also done a certification in Comprehensive Tobacco Cessation Certificate course by Center for Addiction Medicine, NIMHANS. So we are looking forward to hearing from him, from his vast experience about the effects of depression, anxiety, and stress on the developing fetus and the child. Now I hand over to my co-chair, Dr. Indumati, to carry on with the introduction of the topic.
Thank you, Dr. Sri Lakshmi, and thank you organizers for the nice opportunity and choosing this wonderful topic. Because as the introduction Dr. Alim sir said, most of the time we are talking about the side effects, and gynecologists or people are worried about the side effects of medications when mother is given during pregnancy, when mother is given medications. But they are not able to realize or understand the importance of treating the illness, or for that matter, not only illness, it is the stress. Stress itself per se can produce lot of ill effects and permanent lasting effect on the child also. So it is our duty to educate ourselves and also to the our co-doctors like physicians, pediatricians, and also to the public. Actually, in 2021, the same topic we did with Prabha Chandra madam in our Samenvi meeting. The two wordings I still remember is fetal programming and maternal programming. I think if we understand these two words, we'll be able to realize the importance and how to go about it. I think our speaker will talk about this thing in detail. But as we see, last 10 years, the research shows the stress and illnesses can produce not only cognitive impairment in the child, depression, anxiety, schizophrenia, conduct disorders, like so many things. The list goes endless. So we have to be very much aware of these things. So I invite speaker to enlighten us on this very much important topic. Over to the speaker. Take over, sir, please.
Please unmute, Chala.
Thank you, madam. Thank you for your introduction to the topic. And thanks to Alim Siddiqui sir for giving the opportunity to present this topic to other Thursday music team of Patwaji sir and Joe Fanti sir. Start to screen sharing. Coming to the topic, during my first year and second year of MBBS, I learned about the two-hit hypothesis. These two-hit hypothesis, first one is the genetic vulnerability, and this genetic vulnerability with the second hit from environment or any other stressor will lead to the expression of the gene as a phenotype. So, genetic issues will start from straight from the meiosis, during the formation of spermatogonia and during the formation of ovum. So the genetic abnormalities will start far before that. So I used to think that the second hit, like stressor from environment or any other stressor, the second hit may also start quite early rather than fetus being born to the external world. So I used to think that. So after coming to the MD psychiatry, so I used to frequently explore this topic. Why there is abnormality being started? Is it the programming has been started before the birth? So a lot of children who has abnormality coming to the child psychiatric clinic, they have their mothers have significant antenatal stressors. Though they might not be diagnosed, there are significant stressors and domestic violence from their partners. So this slowly, gradually, my interest on the topic has increased. So I dreamed of speaking about this topic at any part of my life, and this is the fulfillment of the dream. I'm thankful to Thursday Music team. Coming to my scheme of presentation, it is the introduction, the history of evidence, development of fetal and infant nervous system, mother and fetus diet, fetal response to maternal stress, and effects on fetus and child, and a postnatal environment promoting resilience, and underlying mechanisms of effects of fetus and child. Conclusion and take-home message. Coming to the introduction, both animal and human studies have shown that if a mother is stressed during her pregnancy, her child is more likely to develop a range of neurodevelopmental problems. And this evidence is at least a part casual rather than one of the associated factors. So due to fetal programming. So, as Honorable Chairperson Madam said, that the fetal programming is a concept that the environment in utero during the specific sensitive periods for developmental outcomes can affect fetal development with a long-term effect on phenotype. So what it means is during the development of embryo and fetus, the intrauterine environment will show its effect during the specific sensitive periods, and these effects will be lead to fetal programming in the nervous system and other body organs, and this will persist for the rest of the life. So research studies have shown that these effects can be persistent at least until adolescence and early adulthood. Coming to the history of evidence, so majority of the studies has been done in the previous.
Dr. Vasan, some audio is not very full. So, are you using any special system or talking to the computer directly? Dr. Vasan, are you able to hear me?
Yes, sir, I can be able to hear you.
Sir, your voice is a bit low and at times echo is there. So, can you come a bit closer to the screen, or you can switch off the video and then talk. So, please come a bit closer to the speaker and then you can talk. Is it okay?
Okay, sir.
Yeah, talk a bit loudly because some people are not able to hear it.
Okay, sir. Sure, sir. So coming to the history of evidence, most of the studies have been done in the previous 20 years in the 21st century. Although the research has been started in the early 1950s in the animal studies. So in the first human study has done in 1973 by Dr. D.H. Scott. So he collected information from 200 women throughout their gestation about their physical and mental and social stressors. He followed the children till 4 years after their birth. So what he found is severe personal tensions, particularly marital discord, were closely associated with child medical illness, neurological dysfunction, and developmental delays and behavioral disturbance. So it's the first earliest human study. A decade after this study, in 1985, Dr. Major has studied the outcomes in two cohorts. So in one cohort, the children are born to war-exposed mothers. In the other cohort, the children is born to mothers 2 years later. So the children born to the war-exposed pregnancies had significantly developmental delays and showed regressive behavior. So later, throughout these 50 years, the evidence got pulled up, and the most consistent finding in later studies is the maternal stress and adverse events increase the risk of attention deficit hyperactivity disorder, anxiety disorder, cognitive and language impairment. Coming to the next decade, in 1994, Dr. Lau et al. Proposed that there may be a fetal stress syndrome analogous to fetal alcohol syndrome. So, on the basis of a study, in this study is found that the antenatal adverse events of mother resulted in low birth weight, smaller head circumference, and lower neurological scores. So, he proposed there might be the features like fetal alcohol syndrome are seen in the children or infants born to mothers who got stressed in their antenatal period. So he proposed a fetal stress syndrome. So he continued the follow-up of the children after their birth, and the continuity showed that 4 to 7 years of their age, the maternal anxiety during the antenatal period had led to the childhood depression. So coming to the evidence of this thinking. So we will go through the evidence-based medicine. So to get to any conclusion, so at the different levels of evidence, first there the animal studies has been done on this topic to know the prenatal insult, which leads to subsequent neuropsychopathology. So they first they cross-fostered the animal kits. So they reared the animal kits in the environment independent of their prenatal mother. And these experiments showed that long-term effects of prenatal stress that provide evidence for significant effects rather than the postnatal factors. Coming to human studies, human studies examined the association between prenatal anxiety and depression and allowing to the all other confounding factors. And finally, they found the clinically significant relationship between prenatal maternal mood and adverse child outcome. And there are further studies about the association between prenatal mood and the aspects of child outcome at birth. So immediately the outcome of the child at birth was found, such that the postnatal factors can be excluded. So that and still they found that there is adverse effects on the child. So that it is progressively known that this effect is independent of postnatal maternal mood and parent. Coming to the comparison between, is it due to the shared genes between the mother and the child, or is due to the maternal stress and anxiety during the antenatal period? So there are several lines of evidence for this research. So in this, they found that these effects are independent of the shared genes between mother and the fetus. So genetically informed study designs, so involving the children conceived in vitro fertilization, where they are not genetically related to their mothers. So in this in vitro fertilization, the ovum was donated by a donor, and that ovum got fertilized artificially in the lab, and it was implanted in the uterus of the mother. So this mother in the child which is born to this mother will be genetically different because ovum donor is different. Yet the maternal stress during her antenatal period led to the adverse childhood outcomes. So studies evaluating the consequences of random exposure to extreme stressors during gestation suggest that the prenatal exposure to stressor exerts a long-lasting effect on the child development. And third one is fetal exposure to synthetic glucocorticoid administration, which exerted the similar consequences of elevated endogenous maternal cortisol. So in the synthetic studies with synthetic glucocorticoid administration, the mothers, even though they are not having any family history or personal history of mood disorders, treatment by the synthetic glucocorticoids during their antenatal period for their infections or any other autoimmune or any other medical condition, including the recent COVID pandemic, when they are treated with the systemic glucocorticoids, it crosses the placental barrier, and it showed effect on the fetal brain, and which later led to decreased cognitive performance, speech delay, and autistic features and symptoms of ADHD. Coming to the twin studies, a stronger support for the programming, this fetal programming influence from mother and maternal programming comes from the study of monozygotic twins. So monozygotic twins, they come from the same zygote. So they almost share most of their genes. So monozygotic twins share single placenta, or it is monochorionic, or they may share different placenta. It is dichorionic. So almost 30 to 35% of monozygotic twins have dichorionic placenta, have their own placenta. So there is a greater intrapair differences between dichorionic monozygotic twins and than between monochorionic monozygotic twins. And this difference is seen in intellectual quotient, personality, and the within pair variability of measuring of fingerprints. So these differences in child outcome are arguably related to different sources of placenta, as they share the similar genetic material as their monozygotic twins. And the other covariates like gestation age and maternal age are similar to the both monozygotic twins. Come to the back to the normal fetal and infant nervous system. So during the embryonal development, fetal development, the human fetal nervous system is a primary target for circulating influences because it shows dramatic growth during the prolonged period during gestation and early postnatal period. So neuronal production in human beings start in the day 42 and it completed by the mid-gestation. So between the gestational age of 8 to 16 weeks, the migration of neurons from the subplate zone and connections with afferent neurons originating from the thalamus, basal forebrain and brainstem. And concurrently, cells accumulate in the outer cerebral wall in of the cortical plate and eventually it becomes a cerebral cortex. And by gestational week of 20, the axons form the synapses with the cortical plate, and by the gestational week of 24, the cortical circuits get organized. So by gestational week of 28, the human brain contains 40 billions of neurons, which is 40% more than the adult. So adult brain has 100 billion neurons. So they will have an additional 40 billion. So overall, it accounts 140 billion of neurons at the age of 28th week of gestation. So there will be a rapid synaptogenesis, which reaches an astonishing peak between the weeks of 34 weeks of gestation to the 2 years postpartum. So there is the perinatal period postpartum, there is the first 2 years. So there is an increase of the synapses at the rate of 40,000 synapses per each minute. So there is a rapid synaptogenesis in this critical period. So coming to mother-fetus diet, is the most intimate relationship between mother and fetus. So even we can make up to the embryo in the lab, but there is only the maternal uterus, the zygote or embryo can be grown into a fetus, into a live viable infant. So this intimate relationship between mother and fetus includes the reciprocal sharing of cells. So the mother cells will be shared to the child and child cells will be shared to the mother. So this placenta is called in Sanskrit as Maya, or some magic is happening in the near the placenta. So these foreign cells cross back to and fro through the placenta and invade the fetus from mother. This is a maternal microbiome. Sir?
Sir, can you be a bit louder?
Can you hear me, sir?
I can hear you. Can you be a bit louder? Small amount.
Okay, sir. Sure. So this cells will cross from mother to fetus and from fetus to mother. This cells invade to the fetus from the mother is maternal microchimerism, and from fetus to mother is fetal microchimerism. These cells apparently survive in both mother and the offspring for decades and perhaps forever. So these cells present in the maternal blood from an earlier born child. So with the previous born child will transfer its cells to the mother, and these cells will also be transferred to the second born or the subsequent born children. So there is evidence that these cells migrate to areas, to tissues where there is a damage. So where there is a damage in the mother or there is a damage in the fetus, these cells will grow from the fetus to mother in the case of damage in maternal organ. But in the case of damage of the fetal organ, the cells will come from mother to fetus. So this reciprocal sharing will be seen in the mother-fetus diet. Thus the potential for maternal cells to influence the risk of health outcomes of fetus has been suggested. Coming to the fetal response to mild to moderate maternal stress. So coming to mild to moderate maternal stress, this will act as a eustress, and the child will actually gain the survival capability following the mild to moderate stress to the mother during her antenatal period. So mild exercises, physical and mental, will lead to the better outcomes in the children. So the fetus can mount its own stress response around mid-gestation, independent of maternal stress response. So mild to moderate stress of maternal stress acts as a stimulator for accelerated brain maturation. So from an evolutionary perspective, this proportion is compatible with the Darwinian theory of survival of the fittest. So individuals who start to adapt to a stressful environment as early as in utero will develop a significant beneficial effect for the better and cognitive and physical capabilities later after it is born. But coming to moderate to severe maternal stress, this leads to adverse impact rather than mild to moderate stress. So regardless of the developmental time period, the fetus will program itself to protect its brain. So maternal adversity will decrease the blood supply to the fetus. So in order to protect the brain, the blood is shunted from the peripheral organs to nurture the fetal nervous system. This adaptation will result in the damage to peripheral organs. So even though the nervous system experiences less deprivation of oxygen and nutrients, but other factors, which I will explain later, will lead to the harmful effects to the fetus, and which makes the fetus vulnerable. So a remarkable fetal surveillance and response system has been conserved across the species to acquire information about the maternal environment. So the human placenta is a fetal organ which collects the information from maternal environment, and it responds with a complex series of signals back to the host mother. So if the prenatal environment is perceived to be stressful and hostile, then the fetus will signal to the mother to promote the accelerated trajectories such that the fetus will be born preterm. So if there is a moderate to severe maternal stress, then the placenta will detect it, and it will send the feedback to the maternal system such that the fetus can be delivered early, and it can get rid of the inhospitable environment. So it will have a short-term survival in uterus. So survival under these moderate to severe stress conditions will lead to compromised fetal growth. So it will lead to intrauterine growth retardation, poor reproductive success. There may be a intrauterine death or a stillbirth, and motor and cognitive and emotional dysfunction. Studies shown that maternal stress is associated with low birth weight and reduced gestational age. The fetus incorporates this bidirectional information to adjust to the developmental programming for the preparation of for survival after birth. So the adverse intrauterine environment will lead to fetal programming of its nervous system. The fetus will prepare for the adverse environment when it comes to outside after delivery. So this fetal programming will be altered field functioning will persist even after the birth. This information between the fetus and mother will lead to its modification of nervous system to adapt to the expected postpartum environment. So coming to the metabolic diseases, so infants who got poor nutrition and near starvation in utero, that is intrauterine growth retardation, if they faced, or starvation of mother lead to increased supply of nutrition during the fetal stage. Those fetus, when they are born out, if they are fed adequately, like any other infant, there will be increased risk of development of metabolic disease. So for the optimal outcome, so there should be a congruence between the prenatal and postnatal environment. So if the prenatal environment is uneventful, then the postnatal environment is uneventful, then the outcome will be, child outcome will be good. So if there is an antenatal depression and the postnatal environment is good, but if there is resilience promoting factors, the effects will be decreased, or else due to incongruence, the effects will be lost. And another probability, the antenatal period will be uneventful, but the postnatal, the mother may have anxiety or depression. This is also a state of incongruence, which also lead to adverse child outcomes. So the infants thrive at least on critical dimensions of psychomotor and mental development when their prenatal and postnatal environments are congruent, even if the conditions are adverse. So even the conditions are adverse, so prenatal adversity and postnatal adversity, the fetus will program its brain such that it will try to thrive after it is born in the critical environment. There is an increased motor and mental development during the first year of life among infants whose mothers experienced congruent level of depressive symptoms during pregnancy and after pregnancy. So what this evidence has shown is if the mother has a depression in the prenatal period, it should be detected as early as possible and during the antenatal checkups, and if her stress has been addressed and her anxiety and depression if it got reduced during the antenatal period, so this will lead to a good child outcome. So untreated antenatal depression or antenatal anxiety will lead to adverse childhood outcomes even at the birth. So even if we treat the postnatal period of the antenatal depression, already some of the damage has already done. So it is best always to intervene as early as possible during the antenatal period. So under adverse consequences and circumstances, the congruence between the prenatal and postnatal environment rather than the main effect of adversity prepares the fetus for postnatal life. And this confers an adaptive advantage for critical surviving functions. Coming to the effects on fetus and infant. So recent studies have shown that prenatal stress is associated with reduced telomere length in the cells. So this will lead to overall reduced life expectancy due to reduced telomere length of the chromosomes. So in humans, higher maternal stress during pregnancy is associated with smaller newborn hippocampus and slower growth of hippocampus across the first 6 months of infants. So this smaller hippocampal volume will later lead to decreased memory power and decreased cognition and emotional and behavioral problems. children who are exposed as fetuses to glucocorticoid treatment had a significant thinner cerebral cortex, and primarily there is a deficit in the rostral anterior cingulate cortex, a region that plays a critical role in stress and emotional regulation. So more than 30% of the rostral anterior cingulate cortex will become thinner among the fetus who are exposed to glucocorticoid treatment. So the magnitude of this effect is substantial. As in the childhood depression, it was shown that 10 to 14% reduction of rostral anterior cingulate cortex will lead to childhood depression. But this prenatal cortisol or glucocorticoid exposure will lead to more than 30% thinning of the cortex. So these neurological changes predict prodromal risk for mental health problems. So 1 point change in the pregnancy specific anxiety scale. So this scale ranges from 10 to 40. So 1 point change in the pregnancy specific anxiety will increase the childhood risk of exhibiting anxiety by 10%. So the strongest association was observed in children who were exposed to maternal depression at 25 gestational weeks. So this at 25 gestational weeks, we have seen previously that the cortical networks are formed at the 25 weeks of 24 to 25 weeks of gestation. So this is the critical period. So this gestational period is also the sensitive window for neurodevelopmental effects of placental corticotropic releasing hormone. So placenta will release a corticotropic releasing hormone, like a pituitary, like a hypothalamus. So fetal exposure to maternal depression at 25 gestational weeks was associated with cortical thinning in 19% of the whole cortex and 24% thinning in the frontal lobe, particularly in the right superior, medial orbital and frontal folds of prefrontal cortex. So the structured MRI, structural MRI scans, which were showing the reduced cortical thickness at 19th week, 25th week, and 31st week, and the maximum effect was seen at 25th week. Coming to effects on infants and toddlers. So infant cortisol and behavioral response was evaluated using the painful stress test, heel stick blood draw. So by drawing the heel stick, blood from heel stick, this painful stress will lead to response in the infant. So it was found that larger infant cortisol response to the painful procedure was associated with previous intranatal fetal exposure to elevated concentration of maternal cortisol during the late second and third trimesters. The studies of infants and toddlers have shown that more difficult temperament and more sleep problems and lower cognitive performance and increased fearfulness was seen in the children born to the mothers who had antenatal stress. So maternal antenatal depression and maternal prenatal cortisol levels have been found to be independent predictors of infant temperament. So maternal stress signals program, this fetal programming, then it increases the reactivity, perhaps leading to more fearful temperament in the offspring. So infants who are easily aroused by varied stimulation are more likely to become behaviorally inhibited as young children, and which leads to social anxiety when they grow up as adolescents. So the consistent evidence that one of the primary consequences of fetal exposure to maternal distress during pregnancy is increased fearful and anxious behavior in infants and early childhood. So associations are also found between prenatal stress and a range of altered physical and physiological outcomes. So alterations in brain structure has been observed and decreased gray matter density and altered limbic prefrontal white matter circuitry. An altered fingerprint pattern and a mixed-handedness has been observed with a right-left confusion, and physical changes have been observed to be associated to prenatal stress, which are determined in utero. So in a general population study, so top 15% of the symptoms of women with 15%, top 15% of anxiety symptoms in a sample at 32 weeks of gestation had shown adverse effects in their children in the later follow-up. So as Chairperson Madam said, not just a clinical anxiety or clinical depression, even in the subclinical distress, accounting to the top 15% of the sample having the highest anxiety symptoms, they too have the double the risk of children having the symptoms with ADHD, anxiety, depression, and conduct disorder at later follow-up at 4 and 7 years of their age, after correcting with multiple covariates. So several studies have found an association between prenatal stress and increased risk for autistic traits and autism. And two studies have found an increased risk of schizophrenia in young adults. So both have shown that severe stress, like death of a relative, shown especially during the sensitive periods of exposure during the first trimester, led to the later development of schizophrenia in the child. So this is when the neuronal cells are migrating to in their eventual site of their brain. So this neuronal migration process has been altered, so which lead to later schizophrenia. So maternal anxiety and depression has been independently associated with occurrence of borderline personality disorder at the age of 11 to 12 years and risk of depression in adolescents and adults. So high maternal depression during pregnancy predicted lower IQ scores in the child independent of the postpartum depression. And maternal anxiety has also shown to have increased risk for scholastic underachievement at 16 years in adolescence. Coming to children exposed as fetus to high level of maternal pregnancy specific anxiety, they has the low scores on both measures of executive function, which are working or sequential memory and inhibitory control. So poor executive functioning is seen. In contrast to the increased HPA axis activity observed after the maternal stress exposure in utero, PTSD may result in decreased offspring basal cortisol levels. So in PTSD, cortisol levels will be elevated in any stressful situation, but the basal cortisol level will be low. So in the patient with PTSD. So if the mother has suffered from a PTSD, this will be this biochemical marker will be transmitted intergenerationally, and the newborn baby or the infant or the child who are born to mother with PTSD also have the baseline cortisol levels to be very low. There's some gender differences in fetal program. So consistency. Studies have consistently showed that males more than female are born preterm, and males have poorer neonatal and infant health outcomes, and they have a high risk for motor and cognitive outcomes, and they have less survival in the intensive care units. So within weeks of implantation, the female placenta is more responsive to maternal changes rather than the male placenta, and the stress signals lead to changes in the female placenta. So if the mother has a mild to moderate stress, then the female placenta will develop its surviving capabilities early. So among females, maternal cortisol was predictive to fetal behavior in response to stimulation at an earlier age than males. This association between fetal exposure to elevated maternal cortisol and placental corticotropic releasing hormone, and delayed neuromuscular development was observed only in males. So female offsprings are more vulnerable to increases in anxiety than compared to male offsprings. So the association between prenatal cortisol and child anxiety was observed primarily among females. So high maternal cortisol concentration in early gestation was associated with larger right amygdala volume in girls but not boys. So at least one standard deviation of increase in maternal cortisol level will lead to 6.4% increase in the size of the right amygdala in girls. So due to increased signs, increase the volume of amygdala, there will be more fear response and the emotional and behavioral problem. So the association between maternal cortisol in early gestation and affective problems in girls is mediated by the cortisol associated right amygdala volume increase. So exposure to high levels of stress in the postnatal life is associated with altered development function of amygdala. Coming to effects in boys. So there is a recent evidence that maternal depression during prenatal period is associated with risk of externalizing behavior in male children. So early exposure to maternal anxiety and depression prenatally are independently associated with externalizing behaviors, significant low verbal intelligence, and low social competence in adolescent boys. So there is a significant cortical thinning in the children, primarily in the right frontal lobe, associated with exposure to perinatal maternal depression in each gestation interval. So this gender-specific effects on the female or male fetus needs further studies and elaboration. Coming to gestational age and outcome in progeny. So new findings indicated that neurological advantages will be seen when it is a near full term and term compared to preterm, and full term compared to near full term. So which means the more the gestation age, the more will be the chances of good outcome. So if the fetus stays in its mother, so beyond 37 weeks, then it will have a further increased cortical volume and neural efficiency. So this has been found in imaging studies also, the MRI and the deep tensor imaging, indicating that the longer gestation age up to 41 weeks, beyond 37 weeks, is associated with increased cortical volume and neural efficiency in 6 to 10 years old children when followed. So being born small to gestational age or being born early was associated with increased risk of other poor health problems like cardiovascular diseases, hypertension, hyperlipidemia, insulin resistance, non-insulin dependent diabetes mellitus, obesity, higher serum cortisol concentration, and shortened lifespan. So there are studies done between the mothers with stressed pregnancy with the mothers who received antidepressant medication and control group. So what they found is placental gene expression was compared between mothers with prenatal depression and/or anxiety or OCD or panic disorder and control mothers without a psychiatric history in a Rhode Island child health study. So in this sample, they concluded that 29 genes were identified as being significantly differently expressed between the placenta from infants of mothers with both depression and anxiety and with depression, compared to mothers who had taken perinatal psychiatric medication and control group. So most of these genes have decreased expression in the stressed group. So compared to treated mothers and controls, the untreated mothers with depression or both with depression and anxiety have decreased expression of the genes, leading to abnormal adverse fetal outcomes. So among placenta from infants of mothers with depression, study found no difference in expression by medication use, indicating that the results are related to stressors rather than antidepressant or SSRI medication. And a meta-analysis was done on comparing between the treated versus untreated maternal antenatal depression. In this meta-analysis, which was published in 2016, they concluded that untreated antenatal depression was associated significantly with increased risk of preterm birth and low birth weight. And the more the severity of depressive symptoms, the more the reduction in the birth weight or the extreme preterm delivery. So comparing the prenatal versus postnatal maternal anxiety, a systematic review reviewed 53 articles on the topic concluded that both the maternal, prenatal, and postnatal anxiety have the adverse outcomes in the child, but there is a stronger evidence for the prenatal maternal anxiety to have adverse impact compared to postnatal maternal anxiety. So coming to postnatal environments promoting resilience. So resilience promoting postnatal environment factors like parental sensitivity, parental skin-to-skin contact, cognitive stimulation or environmental enrichment, social support, and high socioeconomic status. All these factors have found to offset the negative impact of prenatal adversity exposure on the child's internalizing, externalizing, and attention symptoms. So postnatal good postnatal care will reduce these adverse effects which the child got due to prenatal maternal stress. So the mechanism that may underlie this protective and promotive influence on the infant brain functioning may be due to increased oxytocin levels and the moderation of epigenome relevant to the HPA axis and the reduction in the inflammatory markers. So for the moderation of epigenome relevant to the HPA axis, studies indicate that caregivers' sensitivity and touch, physical affection from mother or father modulate the methylation of genes encoding the glucocorticoid receptors, serotonin receptors, and brain-derived neurotropic factors. So by all these mechanisms, the good postnatal care will reduce and develop resilience in the newborn. And this is the schematic representative of early postnatal environmental factors which moderate the effect of maternal stress. Into linguistic stimulation, cognitive stimulation, social support, parental caregiving, and high socioeconomic status. These will all lead to good later child outcomes. Coming to the underlying mechanisms of these effects on fetus and child. So increase in the exposure of the fetus to cortisol in humans is known to have a range of effects on the developing fetus, including brain. So the potentially widespread role for exposure to increased cortisol in human brain is demonstrated by a study using micro and array analysis, in which there is the increasing maternal cortisol exposure affected the expression of over 1,000 genes in fetal brain cells. Coming to babies exposed to synthetic glucocorticoids in utero, there is an altered brain structure leading to thinner cerebral cortex as shown by MRI scans. And then the synthetic glucocorticoids are not bound and oxidized, so they freely cross the placental barrier to reach the fetus. Human placenta will synthesize the placental corticotropic releasing hormone into maternal and fetal circulation, and this placental corticotropic releasing hormone is identical to the hypothalamic CRH in its structure, immunoreactivity, and bioavailability. So there is an exponential increase in the pituitary CRH, especially over the later part of the human gestation, which plays a fundamental role in the organization of fetal nervous system. So in the normal pregnancy, there will be the exponential rise in the placental CRH near the gestation. So near the gestation, acute rise in the placental CRH will lead to initiation of the fetal lung maturity and fetal cerebral nervous system maturity, and it initiates the term delivery. But if there is any maternal moderate to severe stress, then this the rise of the placental CRH will be seen early in the late stage of second trimester or early phase of third trimester. So both the decrease in cortisol binding globulin and the decrease in the activity of placental enzymes which metabolize the cortisol, this leads to fetal exposure to maternal cortisol, ensuring the maturity of fetal lungs, brain, and other organ systems in full-term births. So in full-term births, what will happen? The cortisol binding globulin will be decreased, and the placental enzymes which metabolize the cortisol will be decreased. So more cortisol will be available to the fetal lungs and fetal brain, which will lead to the maturity. But in the maternal stress, there is a early rise in the placental CRH, which leads to an early rise in the maternal cortisol. So at that time, there is no decrease in the cortisol binding globulin or no decrease in the enzymes. So there will be more fetal exposure to enzyme. So the effect of elevated cortisol in pregnancy reflects the priming and programming effect on eventual fetal placental CRH response. So placental CRH levels in women who destined to deliver preterm, before 37 weeks, has a faster rate of increase at significantly higher level of placental corticotropin releasing hormone confined to the beginning of the early trimester than the women who subsequently deliver at term. So placental CRH is the most strongly linked to gestational length. So it is characterized as a controlling factor for placental clock that determines and alters the timing of onset of delivery. So this rise in the levels of placental CRH will alter the placental clock forward or backward. So it will lead to preterm delivery, term delivery, or post-term delivery. So these elevated levels and steeper trajectories of placental corticotropin releasing hormone initiate a cascade of events, resulting in myometrial activation and in extreme cases preterm birth. So fetal exposure to increased levels of maternal cortisol at 15 and 19 weeks of gestation lead to increase in the placental corticotropin releasing hormone at 31 weeks and is associated with decrease in the newborn physical and neuromuscular maturation. So the early rise in the placental CRH at 31 weeks lead to preterm delivery. So there will be a poor newborn physical lung and neuromuscular maturation. Coming to placental CRH is viewed as an evidence that fetus is responding to maternal stress. So in mild to moderate stress or any state in which there is no stress, the placental CRH will be raised later. If it is raised early, it shows that the fetus is responding to the maternal stress. So in prospective longitudinal studies, which assess the fetal nervous system maturation at 25th, 31st, and 37 weeks of gestation, by monitoring the fetal heart rate. Response to vibroacoustic stimulation in 191 maternal fetal diets, they found that placental CRH levels at 15 weeks of gestation, but not later, predicted the enhanced fetal heart rate in response to vibroacoustic stimulation. So even the early rise in the 15th week of gestation will cause further worsening of childhood. These findings were interpreted to suggest that fetal exposure to lowest concentration of placental CRH early in gestation reflect gradual maturity and accelerated neuronal development. So maternal prenatal depression and prenatal cortisol levels has been found to be independent predictors of fearful temperament during infancy. So elevated maternal generalized anxiety and depression during prenatal period, but not postnatal period, were related to increased infant negative behavioral reactivity to novelty. So there is a higher reported maternal pregnancy-specific anxiety between 13 to 17 weeks of gestation is associated with increased negative emotionality in infants. So these findings indicate that fetal exposure to maternal specific anxiety early in gestation may be a sensitive period for programming effects on infant temperament. So fetal exposure to elevated concentration of cortisol and higher maternal stress in the gestation weeks between 13 to 15 is associated with slower mental development at 1 year and lower mental developmental scores. So elevated levels of maternal cortisol in the gestation week greater than 37 weeks, however, soon accelerated cognitive development and response at 12 months. So early rise will lead to adverse effects and later exposure at near term lead to good effects. In utero, cortisol has been shown to be inversely correlated with infant cognitive development at 18 months of age. So in the toddlers, if there is more in intrauterine cortisol, there will be less cognitive development. So the measured attachment using the stranger situation test, they found that this inverse correlation was strong in insecurely attached infants, but absent in securely attached infants. So this insecure attachment will be seen in postnatal depression, and if the antenatal depression continues to the postnatal period. This suggests that the quality of postnatal attachment may be able to buffer against, at least in part, this effect of raised in utero cortisol. This is the diagram showing how the maternal distress is transmitted during placenta, through placenta during fetal period, and through the breast milk in postpartum period. So there will be more exposure to glucocorticoids and more exposure to placental CRH in the antenatal period. And in the postnatal period during breastfeeding, the breast milk will contain more progesterone, less prolactin, less oxytocin, which leads to reduced breast milk secretion in these mothers due to reduced oxytocin and reduced prolactin, and increased sodium and potassium in the breast milk will lead to hypernatremia and hyperkalemia in the neonate, and decreased DHA, which is important for the development of fetal nervous maturity, and increase in the inflammatory markers. Coming to effect of catecholamines as a mediators of damage. A recent study demonstrated that chronic prenatal psychosocial stress during first and second trimesters increases the fetal catecholamine concentration. And this rise in the catecholamine levels will strongly lead to decreased blood supply to the placenta. This is due to the mechanism. The increase in the catecholamines will affect the tone of the peripheral blood vessels. So these hormones stimulate the alpha and beta receptors on the placenta and causes the vasoconstriction of blood vessels, leading to hypertension in placental vasculature and decrease the uterine blood flow to the placenta. Coming to serotonin as mediator. Serotonin is another possible mediator of prenatal stress over the offspring. So during gestation, serotonin acts as a trophic factor regulating the cell division, differentiation, and synaptogenesis in fetal brain. So animal studies have shown that increased brain serotonin exposure leads to alteration in many neuronal processes and subsequent change in offspring behavior. So increase in the serotonin will cause the alteration in abnormal outcomes. So prenatal depression has been found to be associated with downregulation of the expression of placental monoamine oxidase. This enzyme which metabolizes serotonin to its inactive metabolite. As the prenatal depression will lead to decreased expression and decreased functioning of a monoamine oxidase, there will be more serotonin available for the fetus. So this leads to altered neurodevelopment in the fetus. Coming to brain-derived neurotropic factor as a mediating factor. So BDNF is a tropic factor known to be important in the perinatal period in the synapse formation, and it is decreased in depression, and it is raised by antidepressants. So the prenatal stress in the rat model has shown that it inhibits the formation of matured BDNF in the offspring brain. So prenatal maternal stress will lead to decreased BDNF levels, and treatment of mother during antenatal period with antidepressants will lead to increase in the BDNF in the fetal brain. Human cord blood levels of BDNF in the neonates born to the mothers with generalized anxiety disorder during pregnancy were shown to have half the amount of those that of controls. So mothers having a generalized anxiety or depression, these will have neonates born with very low BDNF levels, which will affect the synaptic formation and the neuronal maturation. Coming to immune system and inflammation as mediators. So pro-inflammatory cytokines and their altered patterns during pregnancy has been associated with maternal distress, anxiety, and depression. And studies shown that cytokines' role in mother-fetus interaction demonstrated that pro-inflammatory cytokines does not cross the placenta in normal pregnancy. So in normal pregnancy, the mother cytokines will not go to the fetus. But during the maternal stress, anxiety, and depression, there will be increased permeability of the placenta, and there's more chance of increased cytokine-mediated damage to the fetal brain, leading to premature delivery, cerebral palsy, and bronchopulmonary dysplasia in offspring. Coming to neuroactive steroids. So the primary neuroactive steroids proposed to play a role in fetal programming is allopregnanolone and THDOs. So both are important modulators of GABAergic inhibitory and neuronal functions and modulate the HPA axis function. So during the stress response, there will be reduction in the circulating levels of allopregnanolone at birth. So this results in the reduced production of allopregnanolone in offspring brain. So this reduction in allopregnanolone may reflect the reduced levels of allopregnanolone in mother. So allopregnanolone low levels in mother may lead to postnatal depression, and that's why recently brexanolone, it is an agonist of allopregnanolone, has been approved for the treatment of postnatal depression. So the reduction in neuroactive steroids may be linked with cognitive impairment and anxiety-provoking effects. Coming to epigenetic factors.
Dr. Vasan, sorry for interrupting you. We are running out of time. If
Yes, madam.
will you be winding up soon?
I came to the end, madam.
Okay, thank you.
Thank you. So the epigenetic factors. So this epigenetic modification is seen due to severe maternal stress, which leads to alteration in DNA methylation. These adverse experiences such as physical and sexual abuse in mother will be transmitted generationally to their offspring through the DNA methylation, and this will be showing effect in the fetus for the rest of their life. So the maternal prenatal stress caused by violence by the partner will lead to the epigenetic changes in her DNA and the glucocortical receptors, and the same will be reflected in the adult cells. So this methylation level has been significantly low in the children who are born to the mothers who are treated for their antenatal depression. So if the mother has been treated with SSRIs during her antenatal period for her stress or antenatal depression, this will lead to decreased risk of methylation and a good outcome. These are the summary of the possible mechanisms. Coming to the conclusion, there is a good evidence that maternal stress and anxiety during pregnancy lead to long-term effects on outcomes of children. And the cortisol is probably the main mediating factor, but other mediating factors like BDNF, serotonin, pro-inflammatory cytokines are there. There is evidence that the function of placenta is altered in mother with significant anxiety and depression, and this will control the exposure of fetal brain to hormones, leading to adverse outcomes. These epigenetic changes are likely to underline both changes in placental function and change in the placental fetal brain structure. And coming to the take-home points, though the maternal prenatal stress leads to a lot of adverse effects, maternal prenatal stress is preventable, treatable, and tractable by policy. It increased screening during every antenatal period, antenatal visit, with encouraging talking about prenatal mental health, evidence-based intervention for pregnant women, avoiding stress-inducing communication, stimulating positive postnatal parenting, and benefits of treating maternal anxiety and depression is far more weighing than risk associated with use of psychotropics. Apart from the references, these two books helped me in the preparation of the presentation. I thank Dr. Malay Dave sir for his inputs, and thank you.
Thank you, Dr. Vasan. Thank you so much. It was a very elaborate, exhaustive presentation. I think you covered everything. So you can stop the screen share, take a glass of water and come back. Over to chairpersons for their opening remarks.
Thank you, Dr. Challa, for the wonderful, as Dr. said, it's a very elaborative presentation. I am wondering how much effort would have gone into this preparation. So each and every line has been supported by studies. So from the starting of the study origin, 20, 30 years back itself, you have traced everything. So no one will be able to forget the effect of stress on the baby after this presentation. And what are all the areas, how it has been made, everything you have covered. So I think it's a very nice, wonderful presentation. We can go to the questions, if any, after our another chairperson's remark. Dr. Srilash.
Yes, Dr. Basan has been very exhaustive. I was also wondering how many days and hours it has taken him to make this presentation. I think his last take-home point succinctly summarizes the entire presentation, where he says the risk of not treating is far more than the risk of taking psychotropics in pregnancy. That should be the take-home messages for everyone concerned. And for me, the takeaway was that early detection of symptoms is very necessary, because the postpartum, if you detect or are afraid to use psychotropics during pregnancy and wait for the delivery to take place, you're already too late. And that it need not reach a diagnostic level to start treating. Even the symptoms are enough to raise causes for concern and to monitor and to treat and to intervene. Thank you, Dr. Vasan, for a very excellent presentation. Madam, will you take up the questions or shall I?
Yeah, no problem. If somebody could read the questions, it is easier.
Shall I do that?
Yeah.
So, I think when we're talking maternal stress, a question was put at 9 o'clock which said, would it follow that the milk production in the mother will be affected as also the ability of the newborn to feed, even though active efforts are made to reduce the maternal stress after childbirth?
Doctor, you would like to take up the question? Dr. Salla?
He's talking
From this presentation itself, he has shown one slide how the stress affecting the milk production and what are all the components and how it is having a vicious cycle. I think definitely the stress has impact on the milk production and also the feeding pattern of the baby also, because the stress itself will affect the maternal sensitivity also. When maternal sensitivity gets affected, then that also again have effect on the baby. So in that way, multiple interactions will be there.
Yes, I think so. In principle, yes, but how to quantify, no one knows that. Because again, there is always lack of studies in this area. So grossly, yes, it will be there. So what we should nicely summarize by the chairpersons and the speaker that treating is better than not treating. Dr. Challa, would you agree to that?
Yes, sir.
Okay, so basically, how to quantify the effects? I know there is lack of evidence. There will always be in pregnancy studies because all the findings you cannot do proper experiments there. So how to quantify the effects? So any gross quantification, and you have read the article, you have made the presentation. So what is your impression? How much this stress, anxiety, and depression in mother would affect the newborn, and in what ways? You can you summarize it once again for us? Your own opinion now.
Regarding the stress. So even as I have mentioned in one of the slides, even the subclinical distress will lead to the normal development, neural development. So the fact is, in all the meta-analysis, they have shown that prenatal, antenatal, and antenatal anxiety and antenatal depression will lead to relative risk of preterm and low birth weight to 2 times increased risk, and abnormal behavioral patterns of ADHD or emotional problems, later anxiety disorders, emotional disorders, or personality traits like borderline personality traits. So all these psychiatric issues, the risk will be 3 to 4 times higher than the control pregnancies. So even if we treat with the SSRIs, there is no significant transplacental movement of the SSRI. So only the few studies previously shown paroxetine having some cardiac effects, but later pulled up studies have shown that the risk is less compared to even with millions of population, general population. So the overall the benefit is far more.
Yeah, the question is how to quantify the maternal stress. That is the thing. I think in clinical practice, we see two kind of group of people. One is they are more sensitive towards the stress, anxiety, and all those things. Other one is even they have a significant depression and disorders, then they have a reluctant to take treatment. So those kind of two groups. In urban and all, now a lot of this pregnancy programs are coming up. to take care of their well-being of the mothers during pregnancy and how to take care of the improving the mother baby bonding and all those things. Those kind of things also one side it is developing and other side still we have a struggle in treating. So as much as possible, I feel compare the mother's level of stress from her own version. Previously, pre-morbidly, how was she and how she is, and also assessing the risk factors and also the protective factors and trying to reduce the risk factors or increasing the support system. I think all those things will give some amount of a role in reducing the maternal stress and exposing the fetus into maternal stress and related problems. I think it is my way of understanding and dealing with things.
We'll go to the next question, Dr. Vasan, for you. Mental, though it's a little out of the syllabus, maternal depression in first trimester, which SSRI is least harmful? Is it sertraline? What about benzodiazepines in first trimester? Which is the best time to start treatment of depression, anxiety in the antenatal period as far as fetal health is concerned?
As far as the fetal health is concerned, start as early as possible following detection. So, coming to the best SSRI, the evidence says that sertraline is one of the best and least cost at the present time.
Okay.
Benzodiazepines as much as possible we can avoid in the first trimester. If not, short-acting benzodiazepines will be better.
So what is your take-home message for all private psychiatrists?
All private psychiatrists, they should have good liaison with obstetricians, so such that any antenatal stress which they see in their patient load, they can immediately refer to a psychiatrist for early detection and treatment.
Use of antidepressants should not increase the stress of the obstetrician. So we have to train the ops people that the drugs are not poisonous, they are safe.
Yeah.
We have a lot of evidence, and whatever the basic problem might be more harmful than the drugs that are treating them.
Yeah. In
Also
one article, I read the word psychopharmacoteratophobia.
Yes.
That is the fear, the phobia preventing obstetrician to refer or even the general public to take medications. So I think that part, if we could sensitize, then it will go easy.
Yes. And there's a question by Ramna Rao sir, which says how to balance the risk of behavioral symptoms in the child like autistic features and ADHD symptoms associated with SRIs and other psychotropics.
I think optimal treatment, early detection, optimal treatment would be the best. Because there is no clear-cut answer to all these questions. This is just we are applying our common sense here.
Dr. Vasan, any take on this?
But first we have to see for the indication of the SSRS in the child with autism. Why it has been prescribed. So for any behavioral symptoms in autism, child with autism and ADHD, most of the behavioral symptoms can be addressed by ADHD medication like clonidine or at times with methylphenidate and atomoxetine. So SSRS can be used only when it is needed.
Yes. I think a question from your presentation itself, is there an effect of preterm maternal stress in adult onset depression in the baby?
Yes. The epigenetic modification will be life-lasting. The biochemical markers will be everlasting. So maternal preterm stress will lead to the impact of the child throughout its life. When young adult advancing, any time the child can develop a depression.
And the following question is knowing about the new research about difficulty in conceiving and 40% infertility rate in medicos. How high are neurodevelopmental anomalies in such infants? Possibly indicating a late pregnancy, and how high are the anomalies is what I've understood as a gist of the question.
Yes, due to all the say, increase in the stress, occupational stress, so physical and mental stress. So marrying at the late age, delivering children at the late age. So these are all causing the alterations even in the meiosis and even in the gestational period. So there is more infertility rate. Even the born, there are a lot of children who are born with ADHD symptoms or autistic symptoms. Only symptoms are seen, but there's some.
A very catch
But
22 situation for the doctors.
But there is no actually there is no direct evidence of any studies indicating that the children's in doctors, children of doctors have more risk for neurodevelopmental disorders than general public. That is the topic for further study.
Okay. Okay, so the last question, please suggest some standardized psychometric scales to assess antenatal stress, anxiety, and depression for research and study purposes.
I quoted the PSA scale, the prenatal stress and anxiety scale. These scales are any other scale. I will type my email ID. They can contact.
Thank you. Thank you. I think the time of the session is also nearing end. And the questions are, I think we have covered.
Yes, more or less. Just last one just came in. Anesthetists exposed to inhalant anesthesia have higher rates of MR fetus. Is it correct? Why? Again, a
I
little
think
out.
that has out of the syllabus, but yeah, we can always check and get back. So yeah.
That's
So
all.
I
We
think
are done with the question.
I think we start winding up now. So a few take-home points from both the chairpersons. So what should the audience carry home? Chairpersons, any comments?
No knee-jerk reactions of stopping our medications, especially in a person who's already stable or recently diagnosed psychiatric illness, because the exposure to, I think what we forget is not just a risk factor is not just the psychotropic, but the disease itself is an exposure and a risk factor for the developing fetus. It should be kept in mind. And it is just not a short-term consequence, appears from the presentation that they will persist well into adulthood. So treating our disorders with utmost confidence, knowing that not treating is far more dangerous, is my take home message from the entire presentation.
Yeah, in the same line, increasing the awareness in this aspect rather than the side effects of medication, side effects of untreated maternal stress, depression, and anxiety. That should be the role of each and every psychiatrist, so that from us it will go to obstetrician, pediatricians, and from there to public. Then only I think we can address this problem. Otherwise, it is we only talking about this issue will not solve the problem. It will be very slow also. So I think that we doing that awareness program, when we know all these things, it is taking the thing to others. That is my take home message. So I encourage everyone to do this job rather only focusing ourselves in the clinic, rather than that we have to go out and reach and talk to them in their media, their forum, and all those things. So that will do the work. Thank you for the opportunity, sir.
Yeah, thank you. Those are wonderful points. I think, Dr. Challa, I would request you to make a sort of summary or a sort of a letter to editors thing. You have already collected the data. So if you can just summarize it and have these points supported by evidence, so that we can go as to the next stage, as Dr. Endumati is saying, go to the OBG forum, go to the pediatric forum, and then this presentation has to be made there. So because that is our job also, because they panic whenever the medication is sabse pehle dawa band kar do. That is the first reaction. So the knee jerk, that has to be stopped. They should know that diseases are real and the treatment is helpful. So that is one of our duty. I think it is already 9:30 now, and Dr. Tufan and Dr. Amrit actually are in Gangtok in the conference. So I have the I have the duty of winding it also. So my sincere thanks to Dr. Challa S.V. Krishnavasan for a very exhaustive presentation, and request once again to make it a summary document sort of thing, or publish it somewhere as a letter to editor or a brief review, so that we can take this to the uh, OBG and pediatric people. Uh, Thank you so much for your effort. And both the chairpersons, Dr. Endumati, Dr. Sri Lakshmi, very experienced persons, and bringing a lot of variety, a lot of knowledge to us, and helping in summarizing all these things. So, ma'am, both of you, your presence made our wisdom better. Thank you to the audience, to the Torrent people, and everyone there on this stage for making this a huge success. And we'll meet next week. So thank you, everyone, and good night from our side.
Good night.
Thank you. Good night.
Good